Okay, I'm going to go ahead and get started. So for people who don't know me, my name is Caitlin Martin. I'm one of the generalist faculty here, and I am one of the 3 providers who work in the OB Motivate Clinic, where we provide integrated substance use disorder treatments for pregnant and parenting people. The word we're going to talk about today is not opioids. So I feel like a lot of the residents and students get this idea that opioid use disorder is the most common substance use disorder, but it's not. Actually, alcohol is. But today we're going to talk actually a little bit about stimulant use disorder. And the reason why is it's becoming more and more of a big deal. So I'm going to go ahead and get started, but I'll be happy to take questions. You can put them in the chat, or you can save them for the end, or you can interrupt me. Definitely open to all of those things. Okay. So these are the take-home points. I'll let you read them, but the big ones are, you guys all know, if you've talked to me at all, that substance use, that includes tobacco and alcohol, number 1, and drug use or non-prescribed substance use is a kind of the right term that we're using these days, are common, and they're associated with significant morbidity and mortality for people who use them, including during pregnancy. And then we're talking about stimulants. Stimulants are interesting because they're very different than opioids, for example, and alcohol. They kind of work in different places in the brain and work on different neurotransmitters. So they're called uppers is kind of the name that you'll hear. Sometimes some patients will use, or other people, rather than, quote, downers are going to be referred to more of the alcohol and the opioids. The big thing, just like with every other substance use, is that we have all this data about it, right? People say we have all this great data about the effects of it in pregnancy, et cetera, but actually we don't have great data because it's hard. You can't do, like in everything else in obstetrics, you know, like a randomized controlled trial and give someone non-prescribed stimulants and give someone not non-prescribed stimulants, and then let's see what happens to your baby. So it's really hard to do that. So we have to kind of go off of observational studies, and what I'm going to spend a little bit of time today is talking about some historical lessons learned from the cocaine crisis, as it could be called, where we didn't actually really look at the data before we started putting it out there for the public to know, and why that's led to some issues going forward and how people perceive pregnant people who use substances, and how that continues to perpetuate some racist bias too. Okay, so just to start with updated epidemiology. So this is data from the CDC website where you can go and look at the drug overdose deaths. It's a sad place to go, but you can go and get updated information from the CDC. And so as we all know, it's not anything surprising, since we see this all the time on the news, et cetera, is that drug overdose deaths are still increasing. And what's important to note is that the COVID-19 pandemic made this so much worse. It's very scary. And a lot of this is being driven by synthetic opioids like fentanyl, but as we're talking about today, there's other substances that are usually involved. You can actually, on the CDC website, look at it specifically by state. And so these are the numbers right here, how we've just had an increased number of overdose deaths even in our own state. And actually it was on the Richmond Times News the other day about how overdose deaths are just kind of going insane, and even in our own county. And so on the CDC website, you can also look at the breakdown by substances. You know, the data has some limitations based on toxicology reports, et cetera, but we take what we can get. And so this is Virginia. The CDC has a gap in their data, so you just ignore that. And so these top 2 lines here are opioids. So opioids here, and then this line right here is specifically synthetic opioids, usually fentanyl. So obviously, of course, opioids are the #1 driver of the overdose crisis that we're in, that continues, and it has been exacerbated in the pandemic. But if you look down here, these are the other types of substances. So you see this pink line here and this gray line. they're all the way down here, I know, but you look at the rate of change, they're actually starting to go up in the number of overdose deaths and the rate of change. And this pink line is cocaine, and the gray line is other stimulants such as methamphetamines. And so this is data, again, from our own state. This is the most recent report that came out from the medical examiner's office. So looking at overdose-related deaths, it's pretty sad to read because it's in our own state, kind of in our own backyard. These data are kind of, these data are interpreted and analyzed just right down the street from us. But I took snapshots from the stimulants in here, and you can see this is in Virginia for cocaine overdose related deaths, here just continuing to go up, 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 up. So, as something that we've learned throughout all of these quote waves of the opioid crisis, now the overdose crisis, et cetera, is that the absolute numbers of deaths, of course, and morbidity and mortality is super important, super important. However, what we really need to pay attention to is the rate of change that happens over time. And if we really had done a better job, in the overdose crisis, looking at the rate of change, we maybe could have done a better job at preventing some of these concerning trends and lines that we're seeing. And so this is not a surprise, right? Look, it was starting to go up years ago, and now everyone's like, oh my gosh, this is a big problem. So, but not much was done to actually do something about it ahead of time. So it's quite unfortunate. And you'll see these rates of change too in disparities, and I'm not going to go over all of that today. That's in my other talks that I've kind of talked about in other talks. But when you pay attention to these rates of change, that's how we've noticed disparities between Black and white individuals, and that the rate of change is much more rapid for Black individuals when you're looking at opioid-related deaths, and also men and women for alcohol-related deaths and drug-related deaths, and that the rate of change is much faster, even though the absolute numbers at any point in time might be different. So now we're just going to dive right in, and remember the focus is on stimulants, but again, I'm happy to take questions about other substances, as you guys all know. So just to kind of get ourselves straight, because I know when I was even studying for my addiction medicine boards, I had to kind of get myself straight and what is the right terminology for things, and kind of go from there. So stimulants in general refer to substances that are going to increase that sympathetic nervous system activity, okay, that fight or flight activity, okay, in general. I like the breakdown of terminology as prescribed and non-prescribed stimulant use. I think it makes it a lot clearer, and don't use the word recreational anymore because it doesn't really make any sense in our day and age. Prescribed stimulant use is a thing, right? We all have patients who are on stimulants for different things, ADHD, narcolepsy, etc. And so prescribed stimulants is very normal and it's very useful. When we're talking about non-prescribed stimulant use, I like to think of it as a breakdown of, quote, illicit stimulants. Illicit is a term that's used kind of in national data that's gathered for substances, so that's useful. And that's going to include mainly cocaine and other amphetamines like methamphetamines, MDMA, and then there are some others that were on my addiction medicine boards I'm not going to talk about today, but I'm happy to take questions about it. And then, of course, there's misuse of prescription stimulants. So people who are misusing or using more than prescribed, or using in a different route other than orally, so snorting, Ritalin, Adderall, etc. That's going to be misuse of prescription stimulants. And so all of these are going to be included when we're talking about non-prescribed stimulant use. And today I'm going to focus on non-prescribed stimulant use. I'm not going to be focusing on the patient who's taking, the 10 milligrams of Adderall every day. And, I'm going to be talking about non-prescribed stimulant use and focusing on cocaine and methamphetamine, since those are the most common ones. And again, just to kind of put it out there, I already showed you, I think I got it across how this is a big deal. If you look at those trends in the lines from the CDC for overdose related deaths, but in general, stimulants are very commonly used. So it is a big deal. I know we're not seeing it as much in our patient population during pregnancy here in Richmond, but it's coming. Our colleagues, the other perinatal addiction colleagues that we have on the West Coast, they see more stimulant use disorder than opioid use disorder. So it's going to change, and a lot of it's driven by the drug market. Okay, so again, now we're getting deeper in. So now we're going to focus on stimulants, non-prescribed stimulant use, methamphetamine and cocaine is what we're focusing on. We're going in, and pregnancy. So again, we're getting tinier and tinier from the big picture. So this is looking at trends in substance use during pregnancy. This data is a little old, 2007 and 2016, but it's because we don't have great national data, unfortunately, on substance use during pregnancy. It's usually by a state-by-state situation or by self-report. So we take what we can get. So these are trends that you look at over time in different substances. And so you can see cocaine here. So of course, cocaine use has gone down. That is great. It's so good. I'm glad that cocaine use during pregnancy has gone down overall. But you see the rate of change. You see how even in this during pregnancy, it's starting to follow the general population. Shocker, right? Pregnant people are people, right? So therefore, they're going to, follow the same trends of substance use in the general population. And you guys all know that. But when I talk to other audiences that don't deal with pregnant people very often, they're just confused by that sometimes, like, why would pregnant people use these things? Well, they're using these things because everyone else is using them, because they're people first, then they're pregnant. And then this is amphetamines, so that continues to go up. This is amphetamines, not specifically non-prescribed methamphetamine use, but it is a good depiction of what we see. And this is also consistent with what we see in the general population. So yes, big deal. So diving in, what is cocaine and what is amphetamine? So cocaine, cocaine is derived as plant-based versus methamphetamines is more like man-manufactured. That's one very easy way to think of it and keep the two straight. The two most common types of cocaine that are used, or formulations you want to think of, are going to be cocaine hydrochloride and then crack cocaine, which are going to be the two that you've heard of that patients will tell you that they use cocaine in their crack. Cocaine hydrochloride is typically, it's considered the purest form. It usually comes in like a powder. It's very water soluble. And usually people will either sniff it, swallow it, or dissolve it for injection. Crack cocaine is a little different. That's why it's yellow over here. It can be dissolved in water too. It usually has to be mixed. And so that's why when we're doing harm reduction approaches with patients, we usually will give them clean equipment to use their substances. It's less pure than the cocaine hydrochloride, but usually you heat and dry it and then you can smoke it. Very importantly, and this is the theme of the talk about cocaine, is that even though both of these types of formulations you can think of cocaine have identical physiologic properties. So when people use them in the way that they're used, injection, smoking, however, they have identical effects, right? But when we look at the legal ramifications for possession of cocaine versus crack cocaine, they're very different. So crack cocaine typically in a lot of states does carry higher penalties for possession than cocaine. And a lot of that has to do with the racist policies that continue to exist in our judicial system from the cocaine epidemic, where Black people were generally using crack cocaine more often than cocaine hydrochloride, even though they're the same thing. Methamphetamines, these are the words, a lot of patients will use different words to try to explain what they are. Crystal meth is the most common one that I see, as well, in addition to non-prescribed stimulant use for like Ritalin, Adderall, etc. But when we're talking about the two that we're talking about today, illicit methamphetamine use is most commonly crystal meth that I see. Like I said, methamphetamines are more like man-manufactured versus cocaine is plant-based. You think of it like that. You can make meth using pseudoephedrine, over-the-counter decongestants. That's why whenever you have to go to the store, if you have a cold or something and you're trying to get some Sudafed, you have to give them your ID and then sign something on the little pin pad, is because they track it. They track how much you're getting so they can catch you if you're trying to make meth. Methamphetamines are super high bioavailability, very quick onset of action. Cocaine does too. But methamphetamine is generally has very high bioavailability. You can use methamphetamines in all the different ways: snorting, smoking, injecting, oral use, etc. And so it generally comes in as this like white odorless like powder, and then you can dissolve it. And then usually how it gets smuggled into the United States, for example, it usually gets smuggled in as this liquid or powder, and then you can turn it into the crystals, hence crystal meth. And then you can also press it into pills. What's important to know about all substance use, and you know this, is that none of this is FDA regulated, obviously, right? This is all in the drug market. And so nowadays, anything can have fentanyl in it. So even though you might have a patient whose primary substance of problematic substance is stimulants, It does not mean that that patient is potentially not having fentanyl in what they're using. Because think about it, it's been smuggled in by these people in this liquid or powder form, and it's turned into a crystal or this pill for use. And so you don't know what else is in there. And so it's very important that that harm reduction strategies such as naloxone, et cetera, are being used for all patients who are using non-prescribed substances, including stimulants. Okay, we're gonna, as we dive into the implications of stimulant use in pregnancy, actually we're gonna start with this case. This is actually ironically a case I had as a resident. So I gave a talk on cocaine use in pregnancy when I was a chief resident. And so this is a real case for my residency, and I found this slide, which is quite funny. So I saw a 25-year-old who was at 35 weeks, and she came to triage with vaginal bleeding. She reported some vaginal bleeding, some abdominal pain for about a day. She also disclosed that she had recent cocaine and heroin use, and then she became incarcerated. She has a history of placental eruption in a prior pregnancy, and also has a history of hepatitis C that was recently diagnosed during this pregnancy. When she came in, she was hemodynamically stable, so that's great. She wasn't actively bleeding, but there was evidence of bleeding on her pelvic exam. They put her on the monitor. She had a category 2 tracing, and she had some occasional contractions. Because she wasn't continuing to bleed, it was good. She has a normal coag. She was Rh positive. Her hematocrit was fine. But of course, inconsistent with her report, she was positive on her urine drug test for cocaine and opiates. So she got admitted and was watched on the antepartum service on continuous monitoring. All the consults were made, and then she ended up, the plan was made for delivery given her fetal tracing, which makes sense. But unfortunately, the patient just kind of precipitously went into labor and then delivered precipitously on way to the OR. She delivered a baby who was slightly small. The growth scan that she had done right before when she got admitted showed an AC less than the 2nd percentile, an EFW at the 5th percentile. So again, pretty small baby, and was admitted to the NICU and was being monitored for neonatal opioid withdrawal symptom because the patient had been using cocaine as well as heroin. So we've all seen a patient like this. This is a real patient, and so cocaine use is a real thing. Here in Richmond, we're seeing patients. We generally see patients like this one. It's usually polysubstance use of some sort, most commonly going to be opioids and a stimulant like cocaine or methamphetamine. And so again, don't ever forget that there's probably more than one substance going on. Okay, so what does cocaine do? So cocaine, what it does is it blocks the presynaptic reuptake of all the sympathetic neurotransmitters. Most importantly, dopamine, but also serotonin and norepinephrine, kind of in that order of importance generally. Cocaine is pretty fast. You get the effects pretty fast within a few minutes if you smoke it, within 3 to 5 minutes. For example, and the effects can last usually about 2 hours, but of course it depends on the patient and their metabolism, how they use it, etc. Usually cocaine stays in your system, or you can detect it on toxicology testing, and we have a metabolite that we can test for. So if you send one of those comprehensive drug analysis tests from L&D or from clinic, and it takes a few days to come back and you see it later on, open it up, because if you had a patient who was using cocaine, you'll see the metabolites that are tested for us to confirm that it was cocaine that was in the toxicology test. And because, not surprisingly, because of all the sympathetic effects, it's what we think of first when we're thinking about the physiologic effects of stimulants, it's cardiac, right? So you have that super high effect, that super stimulant effect. And so it's overwhelming the body. The body is not meant to have that level, that super physiologic high levels of these neurotransmitters, which are stimulating neurotransmitters in the brain. And so therefore it goes to the rest of the body, it can have too much effect. So it's not surprising that when you use cocaine, you're at a much higher risk of cardiac events, MI, sudden cardiac death, etc. And so it's a big deal. Cocaine is, of all the substances that are related to emergency department visits, just in the general population, actually stimulants are usually about number 1, maybe on par with alcohol, because again, even though it's not as commonly used as alcohol, it has these terrible effects and can kill people. Methamphetamine is interesting because just like cocaine, it also blocks the reuptake of all those neurotransmitters, right? Dopamine, serotonin, et cetera. But meth also acts directly on the transporters that kind of feed those neurotransmitters into the synapse. And so it actually pushes even more. So meth is really bad. So meth will give you really, really, really high levels of those neurotransmitters all up in your brain. And so, and you think of, and I know most of you have heard my talk just about general how you develop the disease of addiction. It's those super high levels, right, of dopamine, et cetera, that are up and down and up and down. And think about it, meth gives you super, super, super physiologic high levels of these neurotransmitters in your brain. So it's highly addictive because it's just your brain is not meant to have those levels of neurotransmitters. And because of the super high levels of these neurotransmitters hanging out in your brain, it's very neurotoxic. It's toxic to the brain too. So cocaine has all of these things too, but meth has it even worse. Meth has a little bit longer of a half-life than cocaine, but they're still pretty short acting, because even though it kind of lingers it can linger in the body longer, even hours, the effects, so that euphoria or pleasurable effects that patients are getting when they're using them in a non-prescribed fashion, those effects go down much more quickly than the serum levels, for example, would go down in the blood. And so it's very common that people who are using cocaine, and especially meth, that they'll use it in this binge and crash pattern. And I have patients who come to Motivate, and they are getting off a binge and crash pattern from methamphetamine use or cocaine use, and they look terrible. They don't eat, they don't sleep, they don't drink water, for days and days and days. And so I'm glad when they come back, because then we can help them get to a better place, and they made it to clinic, which is a big deal. But that's why, is because of the quick effects and the short acting, but still can linger around the body a little longer, just not with those euphoric effects. And then just like cocaine, it has all these bad effects on the heart: hypertension, MI, cardiomyopathy, stroke. And then meth also has severe dental disease. You probably have heard like the term meth mouth. It's a real thing. And then, of course, anytime you're using non-prescribed substances, you're at increased risk of transmission of infectious diseases like HIV and hepatitis C. So think about what that does to just the general person, non-pregnant person. And then, just like for everything else in pregnancy, it's just worsened, right? So when you have a pregnant person, all those negative effects on the body are just amplified further when someone's pregnant, because of the physiologic changes that come with pregnancy. So the most common complication that you'll see with cocaine or methamphetamine use is going to be, something related to hypertension, just like before. But what's unique is that it doesn't matter how much you used, right? And nowadays you don't even know, right, how potent something is when you're getting it off the drug market, or if there's other substances in there. But it really doesn't. It's not necessarily dose dependent. It really is just dependent on, the use and how the body's doing at that time. And so you can't tell patients that using less is necessarily going to decrease their risk. I mean, less frequency maybe, but not necessarily less of a dose. Because of this hypertensive crises, the most common thing that you will see is that you'll just be confused. Is this preeclampsia or is this not? Just like a lot of other things, right? Like you learned in medical school, you should not be using beta blockers when someone has cocaine in their system because of the unopposed alpha effects. But even though that's not necessarily true in all the cases, it's a good idea. And so using hydralazine when you need to deal with a hypertensive crisis is always a good idea. And sometimes you won't have a drug test back, right? If a patient comes in and it's a severe hypertensive crisis. So when in doubt, if you think there might be cocaine in the system, just use Hydral until you can figure it out. And so, like I mentioned before, everything is worse in pregnancy. But the other thing is that pregnancy in particular, I was reading actually, and I didn't know this, is that the progesterone that's high levels during pregnancy actually can make the myocardial muscle more sensitive to the toxicity from cocaine. And so actually, when people use cocaine during pregnancy, it is even more toxic to the heart than it would be if they weren't pregnant. So that's not good. And then there's all these other things that are associated, right, with with stimulant, non-prescribed stimulant use. Placental abruption, yes, it's definitely out there. The data is like a little bit mixed, but generally does increase the risk. Most associations are positive, the correlations. Maybe PPROM or PROM, definitely changes in heart rate variability, a miscarriage, potentially the data is a little bit mixed. Then of course, just like, using these non-prescribed stimulants is just associated with other things, right? What's the chicken and the egg? We don't know. But we all know that these are more commonly going to be in our patients who are just dealing with a lot of psychosocial burden and then also living in poverty and have untreated psychiatric comorbidities. Polysubstance use is, I think I've said that 10 times, so don't forget, it's not always just one substance. There's usually tobacco, there's usually alcohol, potentially some benzos, and probably some opioids hanging out in there. And so this is a table from a Medscape article that's in press right now that's going over all the different substances in use in pregnancy. And so I highlighted the ones from that big long list on the prior slide. These are the ones with pretty clear data. All the rest are a little bit, the data has some limitations, but it definitely is clear from observational data from, looking at the odds ratios and a dose-dependent relationship that, preeclampsia mimickers, hypertension, and severe maternal morbidity are definitely all associated with non-prescribed stimulant use. So I want to really highlight the last one, severe maternal morbidity. So severe maternal morbidity, you can measure that in different ways. You can measure that with or without blood transfusion, since we know that's the most common thing that we deal with. But this is a paper that came out, I think, last year, looking at substance use during pregnancy. So they looked at cannabis, opioids, and stimulants, since they're the most common aside from alcohol and tobacco, and looked to see the association between this use in pregnancy and severe maternal morbidity. And what they found is that stimulants are all the way over here. So stimulants had the strongest odds ratios, right? So the strongest association with severe maternal morbidity over and beyond opioids and cannabis. And so again, there are all of these like little dots over here in this forest plot with the strongest odds ratios you see over here are all stimulants all over here. So it's a very important substance that we need to be screening for and intervening for. Okay, now we're going to turn to, we went over kind of the effects on the obstetrics, so the maternal physiology. Now we're going to go to fetal effects and just give a little bit of a history lesson. So like I mentioned at the beginning, the effects of cocaine on the developing fetus and neonates has a little bit of a it has a little bit of a history. So starting in the 1980s, this is kind of when the whole like crack baby, thing came about. And so people started kind of noticing that babies were being born during the cocaine epidemic and associating that cocaine use with a lot of things. So a lot of congenital anomalies, cardiac and GU deformities were the most common, et cetera, et cetera, et cetera. And so people started, it would just like blew up in the literature, it blew up in the lay press that, cocaine use causes all of these terrible, terrible things to babies. So again, I know cocaine use is not good in pregnancy, but we need to also make sure that we're saying appropriate information to others in the scientific community and to the public. And so all of these studies, quote unquote, that were coming out during this time in the 80s and early 90s just were terrible in their methods, right? There was all observational data, all small sample sizes, no blinding. So no blinding when you were analyzing the data. So the statistician, for example, who was looking at the data knew, oh, these are the babies that were exposed to cocaine. These are the babies that were not exposed to cocaine. And they also did not take into consideration all of the other factors that could be also contributing to the risks of all of these things that they were seeing that they were saying that were associated with the cocaine, such as the CNS effects, cardiac effects, GU effects. And then there was also just huge racial bias in the data reporting and data interpretation. And so again, these data were not being blinded, and cocaine use was more commonly, or crack was more commonly being used by Black pregnant people at that time. And so again, since there was no blinding at the time of the data and reporting and interpreting and all the things, it just led to a huge association that Black people who are pregnant that use cocaine cause their babies to have all of these bad effects. And that just got perpetuated. And so it took a long time to fix that. But even today, you might be saying, well, I thought cocaine was associated with all of those congenital anomalies. It really is, I mean, it persists today that we think that cocaine use itself, again, cocaine use itself, I know you have to remember cocaine use usually is happening in the midst of a lot of other things, but the substance itself is not associated with all of these congenital anomalies by consistent data. And we started to see that. So in the late 1990s, there was this huge observational study that came out that's found no increase in these physical abnormalities that they had seen in the 1980s. Of course, babies that are exposed to cocaine can have a little bit of that, like a little bit of a withdrawal, if that makes sense. They don't necessarily have a withdrawal syndrome like you have with opioids, but they can have that jitteriness, et cetera, associated with withdrawal. But none of these things that they were reporting on that just went boom all over the place in the 80s. And then it just continued, right? Just trying to catch up, just trying to fix what had already been done. And so into the 90s and the 2000s, again, more and more studies came out in bigger journals, just showing that, again, that these studies that had come out showing the association to cocaine use and these congenital anomalies, these other effects, were not good studies. They were not good, so they did not take into consideration any other factors that could be going on associating with these bad effects. And so again, I'm just showing highlights from pediatrics, for example, so from big journals. So what happened in the very end is that we finally figured out that the differences with cocaine use itself are small and unknown clinical importance. That's a quote from this paper. We do know that cocaine use is associated with low birth weight, prematurity, small for gestational age, like a lot of other things like tobacco. Okay, that is very clear in the literature, and that doesn't really surprise us, right? Given what we know what happens in pregnancies at least to the maternal physiology. But again, all of these effects on babies, either short-term and long-term, yes, there may be there is some correlations with some cognitive and neurocognitive outcomes later on in adolescence potentially, but again, it's all small, and the studies just are not robust enough to show that cocaine use itself is associated with all these things that were published in the 1980s. And so this is a quote right here that came out from this pediatrics paper in 2013 that kind of nipped it in the butt and said, findings are often mixed, with evidence of small but significant associations with development. However, there has not been a strong emergence of clinically relevant findings during adolescence. What is evidence? What is evident are the pervasive effects of poverty on both prenatal cocaine exposure and non-exposed youth. A better understanding of the mechanisms linking early stressors, including both poverty and prenatal cocaine exposure with subsequent function, will benefit the field. And so just to kind of finish out the fetal effects and giving you that history lesson, methamphetamine is very similar. So they have very similar associations too, which is not surprising given that they do very similar things to the body. And so again, the data that is the clearest, it has the same associations with preterm birth, low birth weight, et cetera. There may be some effects on the developing brain. Like I said, methamphetamine is very neurotoxic given the super high levels of the neurotransmitters. But again, though that data is not clear yet, but there are ongoing like multi-million-dollar NIH studies being done right now. So we're hoping in a few years that we'll have a little bit more information about this. So all in all, big picture is that stimulants, cocaine, methamphetamines, non-prescribed stimulant use is bad. It's not great for pregnant people, and it also potentially is also not good for the developing fetus too, but not due to congenital anomalies and all these things that were associated with racially biased publications back in the 80s, but more associated via the normal type of outcomes we think of in obstetrics as preterm delivery, right? And small for gestational age, et cetera, that prematurity is associated with bad things for the baby. But this is a paper that came out looking at severe maternal morbidity, mortality, maternal and neonatal outcomes, and they're looking at non-prescribed amphetamine use, and they actually compared it to opioid use. And if you look at the data here, you can see that the associations with bad things for moms and babies for non-prescribed amphetamine use is actually even stronger than opioids. So again, opioids are a big deal. You guys know that. I'm all, that's what we do every day. But amphetamine use is really bad. So we need to be doing a better job. So just to say very quickly about breastfeeding, when you're talking about stimulants, in general, we just go by the normal breastfeeding recommendations that we do for all other substance use disorders. And this is the recommendations here from all the different professional societies, is that people with a substance use disorder should be supported in their breastfeeding goals if they're meeting these criteria. Essentially, these criteria mean that if they're not currently using non-prescribed substances and they don't have any other contraindications to breastfeeding like HIV, then they should be supporting their breastfeeding goals. So, but if they are currently using non-prescribed substances, then breastfeeding is contraindicated. And so I will just say this over and over again, and I know that a lot of this is not news to people on this call, but you would just be surprised out there what people think, that people with a substance use disorder should not be breastfeeding at all, including if they're in treatment, and that's not true. And so if they're currently using non-prescribed substances, yes, they should not be breastfeeding at the current time. But if they have a history of it, even if it was earlier in pregnancy, that is not associated with an increased risk of that baby being exposed to non-prescribed substances. And there was a paper that came out from Mass General kind of proving, showing that that point earlier this year. Okay, so now we're going to end on how do you deal with this? How do you deal with stimulant use disorder, for example? If someone has a substance use disorder and they're, one of their problematic substances is stimulants like meth or cocaine. Well, sadly, I don't have a Suboxone for stimulant use. Wouldn't that be wonderful? I would love to have a Suboxone for stimulant use. I really, really wish there was one, but there is not. But there are people that are spending their lives trying to find medications that work. But there is so many systematic reviews, so many meta-analyses that just show that nothing really has consistent data. There's a few things here and there that we might use in patients to try to do something, but nothing has consistent data that it works. And so the best thing, the only evidence-based treatment for stimulant use disorder is behavioral therapies, and specifically something called contingency management. Contingency management is a thing that we use a lot in the substance use disorder world, but it's otherwise called motivational incentives, i.e. you do a good thing, like you show up for your clinic visit, you come in, your urine drug test is negative, or etc., whatever your goals are, you get an incentive. You get some money, you get some diapers for your baby, or a gift card, whatever you have in your program. And then if you don't do that thing, you're not punished. We don't take things away, but you just don't get the incentive. That's essentially what it is. And usually you have increasing incentives over time. And so all the data just continues to be consistent that the only thing that has good evidence to improve outcomes so far is contingency management, the motivational incentives, but not medication so far. But overall, what do we do? Well, I'm trying to get contingency management set up in OB Motivate. It's a little hard with logistics, but that is number one, is that treatment programs should be working on that. It's just a little harder to do sometimes than others. And it's probably some type of combination of contingency management and some type of medication. We just don't know exactly what that medication is yet. That's probably going to be, the going forward, it kind of already is the standard of care in some way, shape, or form, even though we don't have great evidence. So this is an example of a study that was published a long time ago looking at citalopram and contingency management and how it did work. So it's probably going to be some type of combination of behavioral therapy and some type of medication. We just don't know what that is yet. But this paper came out last year in the New England Journal of Medicine, and it was the first time we've had some type of positive finding for a stimulant use disorder. This was specifically for methamphetamine. And this paper was a randomized controlled trial at a NIDA CTN site. I think it was based in Texas. And they looked at people with methamphetamine use disorder, and they gave them extended release injectable naltrexone, also called Vivitrol, the brand name, which is what we use for alcohol use disorder, and you can also use for opioid use disorder. And they gave that plus extended release bupropion or Wellbutrin, and they gave that combination of medications and compared it to a placebo group. And they did find positive results, so that's great. And so there's been a lot of talk about this in the substance use disorder world. I will point out though that the overall treatment effect based on their outcomes, which was a little bit complicated with their urine drug test results, was about 11%. So not amazing, but it's not zero, and it was statistically significant. So there is hope out there, is what I take home from this paper. So if you're thinking, well, what am I going to do? Well, what you do is, take care of patients when they have complications from stimulant use toxicity, but then screening, and interventions and linking people to treatment. It's always the answer, right? So you guys know that you should always be screening during pregnancy or in all well woman visits too for substance use. And you also know that when you are screening during pregnancy, you never start the conversation about, do you use drugs or alcohol? You always start with, before you knew that you were pregnant, how much alcohol did you drink? Were you using any prescription medications that are not prescribed to you, et cetera, et cetera. So this is my favorite. This is the SERP. It's only literally 3 questions that has been validated for substance use in pregnancy. And then just remember that toxicology tests are not screens. So the toxicology test that you order when someone comes labor and delivery, for example, and is starting a Suboxone induction, and you get the point of care or the stat one, and then you also send off the confirmatory, so you can know what you're dealing with. Those are great. There's a very, very, very important test. I understand we get a lot of toxicology tests. However, those are not screening tests. The only way to screen someone for a substance use disorder is through talking to them, such as starting with the screening tool I showed on the other slide. And why is that extra important for stimulants? Is because these tests have one, it's not a substitution for a screen. And then 2 is that there's a lot of false positives that you can get, especially with amphetamines and cocaine. They're very common. You can have a lot of false positives when you send off especially those like the immunoassay test, the point of care test, the stat test, whatever the word is, that you're going to get your test back really soon. So these are the ones that we get in the clinic, for example, in the OB Motivate clinic. And so false positives are very common, especially when you're talking about stimulants. You can have false positive results. So it is important to recognize the limitations of the test that you're using. And then again, just after you screen, those brief interventions, using your motivational interviewing that you're practicing in the OB Motivate clinic and hopefully outside the OB Motivate clinic really can make a difference. And when you go out into the real world, you can bill for these things. And what do we do about stimulant use in pregnancy? You literally do the same thing you do for everyone else. You screen, you are compassionate, you're non-judgmental, you do a brief intervention with motivational interviewing, and you do a warm handoff linkage to treatment if that patient is open to treatment at that time. And you guys know how to get patients to us. And that there is data when you're even looking at stimulants in particular, that when these patients get comprehensive care, just like our opioid use disorder patients, their outcomes for themselves and their babies can look similar to people who don't have the disease of addiction. So how many times can you actually help someone that much in medicine? Not super often, but you can for this disease. So those are the take-home points that I had at the beginning. I'll let you guys read those, and then I'll take any questions. No questions? Okay, well, I'll let Liz take it over.